Sir.
Good evening.
Today my topic is structure and function of hemoglobin
Ah,
and hemoglobinopathies and anesthetic implications, sir.
okay.
Structure of hemoglobin. Hemoglobin structure is the one of the first proteins to be studied by X-ray crystallography and earned Max Purge the Nobel Prize in Chemistry in 1962. This red oxygen-carrying pigment in the red blood cells of vertebrates has a molecular weight of 64,450 daltons. Mature RBCs do not contain 95% of cytoplasm with hemoglobin, and they do not contain any organelles. Hemoglobin is produced within the immature RBCs within the bone marrow. Heme is synthesized within the mitochondria and globin is synthesized within ribosomes. Thus, mature RBCs do not produce any hemoglobin as they do not contain any organelles. Hemoglobin is a helical, that is spiral shape of polypeptide molecule with quaternary tetrameric structure comprising of heme and globin portions. Heme, it is a non-protein with 4 subunits, and globin, it is a protein with 4 subunits. So it is a tetramer. Coming to the heme portion. Heme is a protoporphyrin ring, that is a porphyrin derivative with 4 pyrrole rings consisting of carbon, hydrogen, nitrogen atoms, and they do not contain any amino acids. Heme also consists of iron in ferrous state, that is Fe plus 2, held in the center of protoporphyrin ring and coordinated by the 4 nitrogen atoms of porphyrin ring. Each hemoglobin molecule has 4 ferrous molecules, and each ferrous molecule will bind to one oxygen molecule. Thus, each hemoglobin molecule will bind to 4 oxygen molecules. Only the ferrous form of hemoglobin molecules will have the capacity to bind with oxygen, and ferric form do not have the capacity. Coming to the globin portion, it is a polypeptide chains as they are made up of sequence of amino acids. These are coded by chromosomes 11 and 16. There are two pairs, that is 4 of polypeptide chains in each hemoglobin molecule. In normal adult hemoglobin, that is hemoglobin A, the two types of polypeptides are called alpha chains, each of which contain 141 amino acid residues, and beta chain, each of which contain 146 amino acid residues. Thus, hemoglobin A is designated as alpha 2, beta 2. Not all the hemoglobin in the blood of normal adult is HbA. About 2.5% of the hemoglobin is HbA2, in which beta chains are replaced by delta chains. There are small amount of hemoglobin A derivatives closely associated with HbA that represented as glycosylated hemoglobin, that is HbA1c, has a glucose attached to the terminal valine in each beta chain and is of special interest because the quantity in the blood may increase in poorly controlled diabetes. There are 6 types of normal hemoglobin present during human life. 1, 2, 3. Portland hemoglobin, that is zeta 2, gamma 2 chains, Gover 1, that is zeta 2, epsilon 2, Gover 2, alpha 2, epsilon 2. These 3 globin chains are present during embryonic life. Next, fourth one is hemoglobin F, which it is alpha 2, gamma 2. In the body, present in the fetal life, its oxygen content at a given partial pressure of oxygen is greater than that of adult hemoglobin because it binds 2,3 dpg less avidly. This facilitates movement of oxygen from maternal to the fetal circulation. By 6 months, hemoglobin A will appear, and which is almost replace hemoglobin F by 2 years. And fifth and sixth are HbA1 and HbA2. Coming to the molecular structure of alpha and beta subunits, they contain 7 and 8 helicals respectively, named as capital A to capital H, that are joined by non-helical segment. The ferrous present in the heme will bind to the subunit with the binding pocket formed between the helix between E and F. And the heme portion has a proximal pocket to which iron is covalently anchored by a imidazole of histidine residue located on the F helix. This setup allows the iron to bind to oxygen molecules. However, there are other ligands such as nitrate ion, nitric oxide, carbon monoxide, cyanide, sulfur monoxide, which may bind to the distal end of the heme and acts as a competitive inhibitors affecting the oxygen binding. Some of these compounds may bind with significantly higher affinity than oxygen, making these compounds highly toxic to hemoglobin. For example, hemoglobin binding affinity of carbon monoxide is as much as 240 times greater than oxygen. Completion of hemoglobin molecule I described of organization, which includes primary, secondary, tertiary, and finally the quaternary molecule. That is, the polypeptide chain of hemoglobin molecule passes through various stages to finally become quaternary tetrameric molecule. Coming to the functions of hemoglobin. The functions of hemoglobin are broadly classified into oxygen transport, carbon dioxide transport, and buffering of blood, thus maintaining the pH of blood. Coming to the oxygen transport. Oxygen do not readily dissolve in plasma, thus require a transport medium which is a hemoglobin, thus transporting oxygen from lungs to various tissues of body. 97% of oxygen will be bound and transported with hemoglobin, 3% will be dissolved within the plasma. Oxygen binding capacity of hemoglobin is 1.34 ml of oxygen per gram of hemoglobin. There are factors which affect these affinity of oxygen with hemoglobin. First is heme and heme interaction. Binding of one oxygen molecule to one heme subunit causes increased affinity of other heme subunits. There are 4 subunits, so whenever one oxygen molecule gets binds to one subunit, it increases the affinity for the other hemoglobin subunits towards oxygen, which is known as cooperative binding. So it causes increased affinity once one oxygen molecule gets bind. Second important factor is, most important factor is partial pressure of oxygen. Affinity of hemoglobin towards oxygen increases as partial pressure of oxygen increases until reaching a certain point. The relationship between the partial pressure of oxygen and oxyhemoglobin saturation is explained with oxyhemoglobin dissociation curve, which is a sigmoid curve. There is a p-value which refers to the partial pressure of oxygen that is required to fill 50% of hemoglobin with oxygen. That is 50% of hemoglobin to fill the oxygen requires around 27 millimeters of mercury. If there is 27 millimeters of mercury of PO2, then 50% of hemoglobin molecules are filled with oxygen. So in the alveoli with normal PaO2 of 100 millimeters of mercury, hemoglobin becomes 96 to 100% saturated with oxygen. However, whereas at the peripheral tissues where the PO2 will decreasing, which results in release of oxygen from hemoglobin. So it is an important factor, that is the partial pressure of oxygen, which determines the binding of oxygen with hemoglobin, which has increased affinity at the lung level and decreased affinity of hemoglobin towards oxygen at the tissue level. Hemoglobin function has been explained in terms of equilibrium between two classical states, that is tense state and relaxed state. What is this tense state is deoxygenated or unliganded state which exhibits low affinity for oxygen. This tense state shows decreased affinity of oxygen and increased binding to 2,3-DPG. These are inversely related. Whenever there is increased affinity of oxygen, there is decreased affinity for 2,3-DPG. Next is relaxed state. This is oxygenated state or liganded state. It has a more affinity for oxygen, obviously, there will be less binding to 2,3-DPG. Thus, the equilibrium between tense and relaxed state is affected by so many endogenous ligands like 2,3-DPG, hydrogen ions, carbon dioxide, chloride that modulate hemoglobin oxygen affinity either in the relaxed state or towards the tense state. There are conditions which causes right and left shift of ODC curve. Whenever the right shift is seen in conditions with increased 2,3-DPG, decreased pH or increased hydrogen ions, or in hyperthermia or increased carbon dioxide levels, which promotes release of oxygen. This tense state usually occurs at the periphery at the tissue level. However, leftward shift of ODC is seen whenever there is decreased 2,3-DPG, increased pH, hypothermia, and decreased carbon dioxide, which is seen at the lung level. So, coming to second important function of hemoglobin, carbon dioxide transport. A small fraction of carbon dioxide in the red cells reacts with free amino group on hemoglobin to produce carbonic acid, which dissociates to form carbamino residues and hydrogen ions. This reaction provides another opportunity for hemoglobin to act as buffer. It should be noted that heme portion binds to oxygen and globin portion binds to carbon dioxide. Normally, 70% of carbon dioxide is carried by plasma bicarbonate and 20% by erythrocyte bicarbonate, and 5% of carbon dioxide is transported by binding to globin chains of hemoglobin, and remaining 5% transported in solution form. Coming to the buffering of blood and maintaining the pH of blood. The imidazole side chains of histidine residues of globin portion of hemoglobin is the second important buffering system within the body. Within the RBC, the carbon dioxide which enters into the cell reacts with hydrogen ions to form carbonic acid under the influence of the enzyme carbonic anhydrase. This carbonic acid reblated into hydrogen ions and bicarbonate. So at the tissue levels, these hydrogen ions will react with HbO2 and releases oxygen, and hemoglobin will bind to hydrogen ions, thus help in buffer system. However, the bicarbonate will get exchanged with chloride, which is known as chloride shift or hamburger shift. There are other miscellaneous functions of hemoglobin, such as transport and release of nitric oxide, which has attracted intense study in recent years. This nitric oxide, which is carried by hemoglobin, is a key messenger involved in vasodilatation, vascular wall remodeling, endothelial activation, platelet aggregation. So nitric oxide interacts with hemoglobin by reversibly binding to the hemoglobin. Coming to the abnormal hemoglobins or hemoglobinopathies and anesthetic implications. Abnormal hemoglobins are broadly divided into problems with heme portion, globin portion, or total hemoglobin molecule. The heme portion are known as porphyrias, and the globin portion are known as hemoglobinopathies, and dyshemoglobins are dysfunctional hemoglobin as a whole, which can be due to methemoglobin, sulfhemoglobin, carboxyhemoglobin. Coming to the hemoglobinopathies. Hemoglobinopathies are disease involving abnormalities of structure. More precisely, the term applies or the production of hemoglobin. So it can be due to structural abnormality or in the production abnormality. Hemoglobin may present to the anesthesiologist as an incidental complicating factor of a surgical patient or with the problem arising from the disease itself. These are classified into structural qualitative abnormality and quantitative abnormality of globin chains. Structural abnormality. There will be amino acid deletion or substitution. Example include sickle cell anemia, HBS, in which in sixth portion, the glutamic acid is changed to valine and is the most common cause leading to severe hemolytic anemia. There is another variety which is known as hemoglobin C, in which glutamic acid is replaced by lysine, which is a mild chronic hemolytic anemia. Coming to the quantitative abnormalities of globin chain, there will be reduced or no production of globin chains. It can be due to alpha, leads to alpha thalassemia, or beta thalassemia. Alpha thalassemia is problem with chromosome 16 and may result in hydrops fetalis. Beta thalassemia is chromosome 11, problem with chromosome 11. It can lead to severe anemia requiring frequent blood transfusions. Coming to sickle cell anemia, it is the most common in African regions, and hemoglobin S is the most common hemoglobin S involved. At least three interrelated effects are seen with hemoglobin S. The first thing is hemoglobin S is unstable and degrades more rapidly, which is associated with vasculitis. These effects are related to the release of iron and disturbance of nitric oxide physiology. Second important effect is insolubility of deoxygenated hemoglobin, resulting in hypoxia. This hemoglobin S on deoxygenation tends to crystallize and precipitate within the solution, which deforms the cell, which causes characteristic sickle cell shape. The other reason for sickling of cell is due to cellular dehydration associated with cell membrane damage. Third important thing with HBS is increased expression of hemoglobin F, which has a productive effect. So as a result, compared with African haplotypes, the Asian mutations has a more benign course associated with increased level of hemoglobin F. Coming to brief description, clinical picture. This patient may present with chronic hemolytic anemia, vasculitis due to oxidative effects of iron, and progressive end organ damage, and with acute exacerbation. Complications include painful crisis or vaso-occlusive crisis and acute chest syndrome, and may also result in stroke arterial occlusions. Coming to vaso-occlusive crisis, the patient may have present with bone pains due to marrow infarction, usually of lumbar spine, femoral shaft, or knee, or they may present with abdominal pain due to liver infarctions, splenic infarctions, GI dysfunction, or be referred pain referred from fractured ribs. Coming to acute chest syndrome, three possible precipitants of these syndrome include pulmonary infection, bone marrow fat embolism following the painful crisis, pulmonary sequestration and entrapment of RBC leading to lung infarction and injury. And these patients may present with chest pain, fever, tachypnea, and wheezing. So pain crisis and sometimes of acute chest syndrome might be related to unique nature of hemoglobin S. Coming to the anesthetic implications. Management of sickle cell disease includes the confirmation of preoperative diagnosis, a clinical assessment, and anesthetic management appropriate to the procedure and the clinical status of the patient, and the prevention and management of postoperative complications. Children who reach the age of 10 years and have no symptoms are unlikely to have clinically severe form of disease that manifest for the first time in the perioperative period. For those with a established disease, the history examination should identify the frequency, pattern, severity of recent sickling exacerbation, and presence of extent of end organ damage, most commonly brain, lung, and kidney. Adequate hydration perioperatively will reduce the incidence of complication, and the fasting guidelines have been shortened to allow for oral intake of clear fluids up to 2 hours preoperatively. Coming to the transfusion, sickle cell disease is characterized by chronic anemia, increased minute ventilation, increased cardiac output, decreased peripheral vascular resistance, and increased 2,3 DPG, and hemoglobin typically range between 5 to 10 grams per deciliter. So replacement of blood loss should be individual based on patient's baseline hematocrit, end organ pathology, and surgical losses. Coming to the oxygenation, although hypoxia and an increase in sickling are traditionally considered to be a triggering of perioperative sickling exacerbations, there are no definitive clinical accounts in the anesthetic or surgical literature to demonstrate this. So, avoidance of acute hypoxia is a basic standard of anesthetic care in any patient population, as in sickle cell patients. However, there is no direct evidence to support hyperoxygenation beyond the levels is helpful in these patients. And pulse oximetry tends to underestimate true hemoglobin oxygen saturation by about 2% because of high concentration of coexisting with hemoglobin. Coming to thermoregulation and acid-base regulation. Hypothermia causes left shift in ODC curve, thus in isolation would tend to retard sickling. However, maintenance of normothermia is the basic anesthetic aim, and uneventful hypothermia during cardiopulmonary bypass has been reported. Acidosis has been associated as a precipitating of complication and should be avoided. Coming to regional anesthesia. Neuroaxial anesthesia is commonly used for orthopedic and obstetric indications as well as the treatment of painful crises. Coming to the specific procedures. Since cholelithiasis is associated with high erythrocyte turnover, cholecystectomy is a frequent surgical procedure. Orthopedic procedures to treat sickle cell complications such as drainage of bone infection, joint replacement, or correction of musculoskeletal deformity are frequent indications of anesthesia. Use of tourniquet should be avoided. Anesthesia are often needed for neurovascular imaging and for radiological and surgical ablations of intracranial aneurysms. There is a large case literature of cardiopulmonary bypass in sickle cell patients. Most involves reports of correction of congenital anomalies in young children. Although earlier reports described the use of exchange transfusion, more recently there are reports of bypass being performed without transfusion. So cardiopulmonary bypass can be performed without specific alteration to standard practice. Coming to the postoperative care in sickle cell anemia patient, the basic care is early mobilization, pulmonary toilet, effective analgesia, and supplement as required. And painful crisis and acute chest syndrome should be adequately treated by painful scoring with mild painful pain crisis treated with NSAIDs, acetaminophen. Severe may require opioids in the form of TCI or PCI, and consider regional anesthesia where appropriate and psychological support. If there is a acute chest pain syndrome developed postoperatively, administer oxygen, bronchodilators, incentive spirometry, broad spectrum antibiotics, steroids, transfusion in case of severe anemia, and mechanical ventilation in patient with respiratory failure. Next is thalassemia. Thalassemia is a condition which is characterized by reduced or no production of globin chains. It can be due to alpha or beta chains. So there is a disruption of normal balance of alpha and beta producing unstable hemoglobin, which results in rapid breakdown and release of iron complexes, causing damage to the red cell membrane. The clinical features include chronic hemolysis, disturbed nitric oxide physiology, vascular damage, pulmonary hypertension, activation of coagulation factors, and extramedullary erythropoietic tissue expansion in head, thorax, and paraspinal regions. Common indications for anesthesia are cholecystectomies, splenectomy, vascular access needed for frequent transfusion, and repair of fractured bones. Coming to the anesthetic concerns, the patient may present with limited vascular access and hemodynamic control of the vasculopathic population, and bony abnormalities of maxillofacial area may occasionally complicate airway access, making intubation difficult. Perioperative pulmonary hypertension may be problematic, especially in laparoscopic surgeries, and blood loss may be managed with cell salvage, avoiding complications of repeated transfusions. Other congenital hemoglobinopathies are the central issue is the accuracy and interpretation of pulse oximetry in the presence of abnormal hemoglobin. Co-oximetry using multiple waveforms allows analysis of multiple hemoglobin may provide a more accurate picture than pulse oximetry. As an alternative, measurements of ABG can be used as an estimate of arterial oxygenation and delivery. Coming to the summary, hemoglobinopathies are the large and diverse group of disorders that present many interesting and challenging situations. The common problem related to the instability of hemoglobin molecule are often present in these disorders. So close communication, collaboration between a surgeon, anesthesiologist, and hematologist are essential to ensure the safe and optimal management of people with these disorders. Thank you, sir.